It is such an honor to be here, to be moderator of this panel, but not just as moderator, to be here as a friend of Nancy Davis, who I've watched turn her own personal pain into a passion. And through what she has experienced with the loss of her son, she is taking that and funding and raising money for research and giving families hope, families around the country hope. And today we're here to talk about what's next for that hope. And we're surrounded by like some of the brightest in the business. I'm going to give you an introduction to all of them. We have researchers, we have advocates, and we've had people who have had addiction, whether it was something they experienced or their families. So first off, you all know Nancy. Nancy Davis is the founder of Cure Addiction Now and has been funding groundbreaking research and bringing heart and hope to everything that she does. Next to her, we have Lisa Vidal, who is an actress and an advocate who trailed me once in the newsroom so she could learn how to play a newscaster on TV. She is sharing her family story after losing her beloved son. She's also talking about using her platform to get beyond the stigma of what so many families experience. Colby here on the end is a recovery addict, but not only that, he is someone who has been able to completely transform his life through the addiction that he faced. And we're so excited to hear how you did it and where you are in that now. Isabella behind me is the co-chair of Cure Addiction Now. She is one of Nancy's daughters, and she's taking the family's history of raising money to help others and really taking that by the horns as a junior in college. And so proud of her. I've known her since she was a baby.
We both had twins.
Yeah, our twins used to play together. Dr. Kelly Dunn at the end, at the forefront of opioid use disorder research. So I'm excited to hear about that. Also focusing on genetics and the withdrawal and long-term recovery solutions. Next to me, Dr. Adam Kaplin. Nice to see you again. A psychiatrist, a neuroscientist, and a biotech entrepreneur. So he's smart. Yeah, he's smart. And he's developing all types of therapies to repair brain systems that have been affected and impacted by addiction. Next to him, we have Dr. Kurt Rasmussen, who is the chairman of Cure Addiction Now Scientific Advisory Board, an internationally recognized neuroscientist and former NID director. He is leading innovation in therapeutic discovery for addiction. Dr. Sharon Walsh at the back is Center on Drug and Alcohol Research for University of Kentucky. So nice to meet you. She leads the $350 million Healing Community Study, one of the largest national efforts to reduce overdose deaths. We have Dr. Andrew Chambers next to her, a leading addiction psychiatrist and neuroscientist. His work is kind of redefining how we understand the connection between mental illness and addiction, which, as we know, is such a strong one. Dr. Paul Kinney behind us here, chair of neuroscience at Mount Sinai. Dr. Kinney's research explores how addiction alters the brain chemistry, laying the foundation for the next generation of targeted treatments. And next to him, Dr. Kathryn Cunningham. She has led over 30 years of NIH-funded research uncovering how the brain signaling and new molecular targets can transform addiction treatment. And I want to get to Nancy soon, but I'm going to start with Colby first. She really wanted me to start with Colby because Colby has been able to transform his life. And I think people can talk about it all they want, but until you've lived it and you've been in the trenches, you don't really understand. So can you kind of take us through what started your addiction and how you were able to get out of it and have continued to stay sober?
We only have an hour and a half.
Yeah,
right?
sorry.
Yikes. Well, how I overcame it was definitely like a long time of constant downfalls and trying, but there was always that try in me. And I've always, I think one of my big turnarounds the very last time was when I've tried so many times. I kept falling, and I was like, there was no more. I knew that there was going to be a bigger life out for me. I knew that there was way more than jail, getting in trouble, more jail, looking at prison time, homelessness, all of that fun stuff. Um, there was just more out there, you know. And luckily, this is definitely a disease, and it was ran through my family. We've lost so many people in our family, my brothers, cousins, aunts. There's been so many people who have their lives have been lost due to this disease. And um, I I just yeah, I was done with it. So luckily I had them to like kind of a lot of them were sober, and so at the age of 14, I was introduced to NA and AA even before I started using, which is I think a good backbone to get started. But as you guys know, like NA and AA only work for what's like 7% of people, I think. So there's so many other avenues that I've kind of focused on this last time as well. Um, but yeah, right after high school, I went down a dark path. I just has always been an explorer, let's say, and I tried a couple of things, and I was like, it just really, I live a gay lifestyle, and I just felt immediately comfortable with myself. When I started it, everything just seemed brighter, and it just led me nothing but the trail of destruction behind me. Um, but I also, standing here today, I wouldn't have changed it for the world, because the further I get away from that old self, the further I disconnect from it. And all I can say is like it was a feeling like someone else was in the driver's seat for all those years. Like someone else was there. I was there. I remember it, but it was someone else in the driver's seat. Sure, I could make decisions, but it was so focused on getting that next high or that next, like, so it feels good the longer you have, and it takes like the brain like a full year to even recover from something like that, or longer, because I keep saying just a year, but every year that I am sober, and it's been what 5.5 years now, I feel like it's changing my brain more and more and more. So um yeah, I just 5.5 years ago, I went. It's kind of funny because we're sitting right in front of where I got sober, right in Laurel Canyon up here, and it's funny that we're sitting here today, right in front of it. So that's pretty exciting. But I was bartending for like 10 years before that. Actually, right out of treatment, I went right back into bartending, and I was like, I got to figure out something else to do. So I went to beauty school. I was like, well, an addict can do that, I guess. That seems about right, the right avenue. But I immediately started my own salon called Chemically Dependent. I had to.
Amazing.
I had to fit that, and then speaking of stigma, I just don't care. Like, it's right in the middle of town at a huge shopping center, and it says chemically dependent on with graffiti, overdosed on confidence right below it, like a little tagline. I'm just doing my own part in my own community, trying to like take the stigma away from, sobriety. How it could be a scary thing. When I went to treatment, it was a great treatment center. It shouldn't be scary. It should not be a scary thing to do. It should be actually really exciting. It's just a different life, but you have so much more abilities. Like an addict that's sober, it's like a superpower. You can do anything you really set your mind to. Like I have a criminal record that has not stopped me. I couldn't even get a job at Starbucks, but yeah, I'm able to buy my second house this last year. So it's like you can do things that you set your mind to. You just have to go out and do it.
And now you're helping others. It's
Yes,
amazing,
yeah.
amazing story. Nancy, I want to get to you, and then I want to talk about, is my mic not working? Okay, is it on?
Yeah.
Okay. This started out of a very painful time in your life and your family's life. For those that don't know, can you just walk us through that a little bit?
Yes, I had the most wonderful son, Jason Davis. Loved him more than life itself. he was very anti-drugs. I knew he would be the kid who would never become an addict. He was in a movie with Chris Farley at some point, and Chris died about a year later. He was in Beverly Hills Ninja, and then Chris died, and Jason was just devastated. And in his high school, he started his own, sobriety thing and anti-drug thing. He'd have events at school. He'd even have events at stores on Rodeo Drive. He was so against it. So I kind of knew he would never be the kid who would take drugs and become addicted because he was so against it, and it hurt him at age 12. And he'd written this really great script at age 12 called Just One More Day, and how he could, if he could bring this person back, what would he do, and what would he tell them, and how would he educate them about drugs. And it was really interesting. It got optioned for a TV movie of the week when he was 12 years old, which was great. But I knew the energy and force that he had, he would never become an addict. Cut to, he's 21 years old. He has an injury on his back. He's at his brother's wedding, which wasn't going well. And he burned his back, and something happened, and his friend said, I'm going to give you some opium and it'll really make your pain go away. And I would think he was smarter than to fall into that, because of his history. But all of a sudden, he had his first dose of that, which is the candy-coated way of saying heroin. And he just went from 0 to 100. He hadn't had drinks or anything. He just went right there. And it just wrapped its way around his brain. And I think he spent the rest of his life trying to chase his first high. And he did well for a while. And then he'd get, he was sober, then he'd relapse. And he was sober, then he'd relapse. And going to different, meetings, going to rehab. It was very expensive and very depressing. And I learned way too much at that point. But I guess the thing I learned most is when as parents, when we have a sick child, we're used to going to the doctor and the doctor giving us medicine or something to help our child. You couldn't just go to your pediatrician or somebody and say, what can we take? There's just no great answer, and there was no great remedies. And we tried lots of things. And Jason went through a 12-year battle off and on of becoming an addict. And he came to me one day and he said, Mom, I'm going to way too many funerals of my friends. You don't go to any of them, but I am. My friends are very young. And he goes, why is this happening? He goes, I've tried AA, I've tried the 12-step program, and it's great if it works for you. He goes, I think I could teach the classes. I know exactly what to do and what to say, but when I relapse, I get in a dark moment, it doesn't help me. And all I want to do is have drugs. It's just speaking in my head. I want to have drugs so badly. He came to me, he goes, Mom, we're going to start a charity called Cure Addiction Now. I'm like, no, we're not. I don't have any energy. I'm already running a charity for MS. He goes, Mom, you don't have time not to. I'm like, okay, you're right. So we set out to start this charity, and Jason was there when we got our 501c3 in our first meetings, and some of these doctors here knew Jason. He came to the first meetings, and he was so happy and so proud because he felt he could save a lot of people. Because he loved to help people that when they were sick. It was always his thing. He always knew how to connect with doctors and this and that, and he just wanted to help people. He wanted to help himself too, of course. But unfortunately, we had our first meeting, and 4 months later, Jason had been sober for 9 months, and he took his first drug in a long time. And 4 days later, he, I guess, got COVID, and he died of a double pulmonary embolism. Everyone thought it was definitely an overdose, which I think being on drugs for so long and all that does make you susceptible to dying very young of other things. And so it was just really upsetting, and I didn't know what to do. That was the worst thing, the worst phone call of my entire life, that my son had died. I loved him. He was so full of life. He was so much fun. He was so loyal and so much fun. And from the minute I got that call, oh my God, my life has absolutely never been the same. It's just devastating. It's hard to get over it. Being here today, we are, he died 5.5 years ago. We're probably 6.5 years into this charity, and looking what we're doing today, I have to do this. I am obsessed. This is Jason's dream, and honoring his legacy and his memory. I'm going to make this happen no matter what it takes. We need to find medications. We need to find cures. We need to take the stigma away from this disease and make people feel bad, even to make the parents or loved ones of that person feel bad. There's no room for that. It is a disease. It is a bona fide disease, and we need to call it what it is. And we need to come up with with lots of remedies, and it's definitely not one size fits all. And so many people are wired differently from the day they're born, and you don't know who's going to become an addict. You can't predict that. I would have never thought Jason would be that person, but then he was. And I feel his presence every day. We're doing a big event tomorrow night, and I feel the harder I work and the more we're doing in a given day, I'll look at the sunset at night.
It's the sunsets
I
for
see
me.
these sunsets, and the bigger the sunset, the more we've done that day. And I feel it's Jason's way of saying thank you. And if Jason was here, which I know he is in some capacity, he would say thank you to each and every person who's working so hard in this. He would be so grateful. And I can't wait for the day that every parent, when they find their child has this problem, can go to their pediatrician and get medicine, a vaccine or something. And we're working on all those crazy ideas, and they were all Jason's ideas, not mine. And we are doing them. And this brilliant team of doctors here, they are making Jason's dream come true. They are making my dream come true. They're making my daughter Isabella's dream come true. We want to make this, we want people to have dignity who have this disease, and we want to find cures.
Well, Nancy is like a dog with a slipper, and she will not finish until she's gotten the job done. It's unbelievable, and you are a living example to all of us.
Thank you.
We're going to hear more. We're going to hear from Lisa and Isabella in a moment, but I want to talk to some of the doctors about where we are, kind of what the state of addiction is today, and how it's changed over the past, say, 50 years. Is there anyone who would like to take a stab at that one?
Sure. So I think we have come a long way in 50 years in some regards. So we, I think, now fully understand that it is a brain disease and medical illness, and that it's something that we can intervene on with medicines. I do think that we still have room to grow in terms of the types of medications that we are developing and administering. So we haven't had a lot of growth in that area in the past 50 years, but we recognize now that that's what's needed, right? That this is a medical illness, just like numerous other medical illnesses, and that as soon as we can start to find more treatments in line with the medical illness, that our patients will continue to do better.
And as you guys are working on looking at the vaccines or cures, it feels like the landscape is ever changing because you have new drugs that are coming forward. We have fentanyl that we hear so much about. And how do you combat dealing with all these new things that are coming into the market?
Well, hello. Yes, hello. You start researching them. You have to be agile. I think things are always changing in this community. And Kelly and others have done a lot of work into examining how fentanyl withdrawal is very different. And there's a lot of preclinical work going on to see how it's affecting the brain differently. And things are always changing in this field. So you have to be very agile and come up with new treatments and do new research.
If there's one thing that you could change, any of you, about how addiction is viewed, what specifically would it be?
I think it's pretty clear. The word stigma has already been mentioned. I think not enough people understand that it is a brain disorder. It's not a lack of willpower. It's not a character flaw. One of the problems is it typically starts out as voluntary consumption. So people think, well, just say no. That'll stop it. But after repeated consumption, literally the brain changes, and it becomes an uncontrollable compulsion. The brain has been rewired in many ways. So I think that stigma of blaming the victim, of treating them as the modern day lepers, like people will eventually look back on how we treated people with addiction, substance use disorders with disdain. And I think we will make progress with this. I think one way to make progress is something that Cure Addiction is working on now, is to help develop new treatments. And introducing new treatments will in turn hopefully change society's attitude towards the stigma. People will understand that indeed it's a brain disorder. It can be treated with medicine. We need multiple types of treatments, but I think that will be transformational if we get more treatment options out there that'll help the patient, but also change society's attitudes.
It's the shame. I know in my family, I have a sister who has now been sober for a year and a half, but she didn't tell us for the first 6 or 7 months of her sobriety. And we were shocked. We're like, we're so excited. Why wouldn't you tell us? And she's like, I was embarrassed, and we're a really supportive family, but it was a secret that she had, and she had so much shame and how it led for her to become a parent to her daughter. And it's painful to see to this day, even though there's a year and a half of sobriety, how she still views it. And speaking of addiction, because there's multiple addictions in my family, that brings us to the issue of genetics and how that plays. You mentioned, Colby, your family has multiple people who have struggled with this. So any doctor want to take on that subject?
So, just because you bring up Colby as well, so I think that one of the aspects of the stigma is that it overshadows the fact that many people have a vulnerability because they're the kinds of individuals who enjoy novelty and new experiences, and they're open to that, and they really do get charged up and excited about new things and rewarding situations, and for them, they're the explorers of the world, but then they end up, unfortunately, the other aspect of it is you have to keep in mind that this is a business, a multi-gajillion dollar business, so that the drugs that are available now are the most addicting substances ever discovered by mankind, because that's what sells.
Like OxyContin.
Yeah, exactly. So, you're taking people who have the ability to be explorers and start, entrepreneurs, and really enjoy life, and so that is part of the genetics of people who are very, interested in novel experiences that are really reward focused, that don't mind the setbacks, the punishments don't really get to them, and those are the people who will push forward. But these are very addicting drugs, and they can also get really hooked on them. Part of it. But please, anybody else who wants to contribute?
That word stigma keeps coming up, and then I just had a thought of, and I'm really happy Nancy Davis has me here to share a positive story, because I feel like stigmas come from negative experiences, and that's where it all comes from, whether that be a disease or something. So if we can have more light and some more stories of positive things coming out of diseases, it'll change people's minds of addiction being so scary and so bad and so negative, because it's something that it can come through. A disease is only so scary as it's being so negative. If there's so much hope and so much other, positive changes or people coming out of that, I feel like that will really help change the dynamic of addiction being scary.
That's why I really wanted you to be here today.
Yeah, keep pushing.
You've got a great story, and it is possible. And you got to celebrate the positivity. And when someone's life is saved, it's the most important thing.
Narcan is something I know that Nancy and Isabella worked on. Isabella, do you want to talk a little bit about that? Didn't you work on a project for that?
With Narcan?
Narcan?
For Narcan, we did a few PSAs to show how to use it in case of an emergency. And we do hand them out at all of the events so that people can have it in their car, at their home. It's now being in all the schools, and we're trying to get it in more places so that you're always able to carry it.
We talk about the stigma and the shame. Isabella, how was it to be a family member to watch this happen to your beloved brother?
It was very difficult to go through. I think that I grew up learning about this disease and trying to understand it as best as I could as a disease. And obviously, at a young age, it's hard to understand everything, but the more I grew up, I realized what Jason's battles were, and that as a family, as his sister, I needed to support him as best as I could and love him, because he was trying for a very long time to be sober, and he really was someone who just in 1 second got hooked on something at 21 years old, and he couldn't handle not having something at the time. And it wasn't his fault, I don't think. And so I tried to give him as much love as I can. And then obviously now everything we do is in his memory. And this all started because of him. He had this idea that he really wanted to help people like him, people who did not have accessibility, did not have the money to go to rehab, different ways to help his friends. And I think it's just really important that we're here today.
Well, you're amazing, and I always go back to the fact that you're a junior in college, juggling all of this. You're juggling the emotions of this. You're helping your mom with the foundation, and you're being a college student. So I'm very proud of you.
I'm so proud of her.
Yeah.
She's really a good soldier in this battle.
She's a good girl. There's been a lot of talk about the GLP-1, am I saying it right? The weight loss drugs, and how can that work and the effects of that with addiction?
I want to get Paul Kennedy to say a few things. I'll say a couple of words, but Paul is the expert behind me. The GLP-1 agonists are having surprising effects on various substance use disorders. There's anecdotal reports of alcohol use disorder. And some of the initial, one thing to keep in mind that there's two types of weight loss drugs. The GLP-1 agonists, like Ozempic, but there's also new things in development called co-agonists that hit another type of peptide called GIP. So think of those as they hit two agonists, or two receptors. And it seems like the ones that hit two receptors, like Zepbound, for example, seem to be particularly better for neuroscience indications. And a very promising development just recently is that Eli Lilly, who makes Zepbound and does a lot of the GLP-1 compounds, just started 2 phase 3 trials for alcohol use disorder for one of the co-agonists that's not on the market yet. Believe me, I worked for Lilly for a long time. They would not do that. Those are enormously expensive. They didn't feel very strongly it was going to work. And I think the co-agonists, some of the data I've seen with the semaglutide, just the GLP-1s, it helped, but it wasn't that impressive. I think the co-agonists could be very important. So and they also tease that they're going to do the same compound in opioid use disorder. So I think we're really on the cusp of a sea change. Not only do we have a big pharma finally interested in substance use disorder, but I think these compounds will have an effect and be part of a new arrow in the quiver. It won't be a magic bullet, but as these proceed forward, we can learn about them, and Paul will tell you about what he's learned about the GLP-1 agonists and how they work in the brain. But I think it's incumbent on all of us to start looking at the co-agonists, the ones that also hit the GIP receptor.
I mean, that is exciting. Do you want to go ahead and take over?
Yeah, I mean, it's great to see that the data in humans are coming through now, or it looks like these GLP-1 agonists and the co-agonists are potentially efficacious. It's still early days. These studies are, some cases, just being initiated, as Kurt mentioned, the Big Lilly study. So many of us are waiting with bated breath, but this was predicted. The preclinical literature, the animal studies, predicted that GLP-1 agonists would be efficacious probably 15 years ago. And it's not just GLP-1 agonists. There are other mechanisms that the preclinical literature suggests can and likely will be efficacious in humans. So my hope is that if we see these drugs work in humans, that they decrease alcohol use and dose of alcohol use disorder, that will support the basic science, and that if companies like Lilly will step in and they see in market and they see it's possible to develop these drugs and you can see that they work, it will be the first of hopefully many, many therapeutics, because we've all been working, I think, diligently in the background. We think we have an insight or insights into how addiction works. We have potential therapeutics, but what's been missing to a large extent has been companies stepping in and helping move them into humans. And so it will be great if that actually begins to happen.
Are there any other breakthroughs that you're looking at, or any other exciting treatments, drugs available to combat the drugs?
I think Kelly's worked on one of these mechanisms. There's a drug on the market for the treatment. It's a sleep aid, suvorexant. So it's a drug that blocks two receptors in the brain, two very closely related receptors, the orexin 1 and the orexin 2 receptor. If you block the orexin 2 receptor, it facilitates sleep. That's why that drug is on the market. But we've known perhaps for longer about orexin 1 being implicated in regulating the motivational properties of addictive drugs than we've known about GLP-1. And so there's tremendous interest and promise around orexin 1 receptor antagonists for the treatment of drug addiction, and there's actually a few now in clinical development.
There's one other, sorry, Kelly, there's one other compound that's in development I'm very excited about. It's called tizampanil by a company called Proneris, and it blocks the withdrawal symptoms of opiate use disorder and helps ease the transition in a rehab center, in a controlled setting, from addiction to either an agonist or an antagonist. And Dr. Chambers is sitting right behind us. He's the lead investigator on that study. Maybe, Andy, you could share a little bit about that?
Yeah, so this comes up too with some themes that we talked about, or you all talked about in our earlier podcast, and that is we're really hopeful for this glutamate AMPA antagonistic drug because the glutamate system is deeply wired into not only circuits of multiple addictions, but also mental illness circuits where there's a connection. And, opiate withdrawal is a type of short-term psychiatric illness and very, very physical illness all through the glutamate system. So we're excited about this drug because it may actually treat both the addiction and the withdrawal kind of simultaneously because the glutamate system is involved in wiring and plasticity in the brain, and we believe we can pulse that system to change, hopefully jumpstart a circuit change, so to speak. And that's really, that's a theme that came up earlier. We really have to have interventions that change brain circuitry because you're trying to, in a way, erase the memories and the motivational circuitry that drives addiction and drives drug seeking and drug compulsive use. And we're trying to, change the wiring. And when you do that in the brain, you change what the brain knows. And it turns out motivation is a highly coordinated, neural system that works on neural wiring, and it works on information processing and learning and memory. So we're trying to change those circuits. And what's exciting about tizampanil is it may be a treatment you can deliver when someone's at that key transition of withdrawal or detoxing, we call it sometimes, but going through opiate withdrawal. But then it may also, we hope, sort of boost early recovery into sobriety because it may disrupt the memories of drug addiction. We're very excited about that. Now, this is, taking animal modeling work and a lot of animal modeling work of tizampanil that Kurt actually started. He is the grandfather of tizampanil because this work started in rats 25 years ago. Again, and you'll hear this, like, why does it take so long in the addiction field for knowledge to translate? It's pretty frustrating. But anyway, we're excited about the drug for that reason, and we're undergoing a clinical trial now in Indianapolis at IU, and we'll be talking about some of the early results of this Monday, actually. Tomorrow.
Can I also, even though it may not sound as super exciting, it's still incredibly meaningful, and since Kelly can't necessarily sing her own praises, nor can Nancy, let me just mention to you that Nancy's foundation is funding a project that Kelly is heading up to make sure that the different locations are all getting the same information. So how do you know if one drug is working as well as another, if the kinds of outcomes for withdrawal, for instance, are different scales that are being used? Wouldn't it be great if everybody agreed on the same scales so you could compare what's being done at Maryland with Hopkins, with UCLA? And that's exactly the kind of breaking down walls that Nancy has continued to do in MS as well as in addiction, and that's what Kelly is heading up so that now the entire field can move forward. So sometimes, knowing that the money is going to really pull people together and make it a different system of the way people are doing the studies can make a big difference too.
Kelly, we want to add anything to this?
Well, thank you for that very kind acknowledgement of the research. I did want to add one thing kind of to expand on this. And what I think is really exciting about these 3 different medication types that were just described is that they, are, in my mind, kind of represent the next phase of this type of work because they're not focused on a very specific substance use disorder. They're focused on general symptoms that are true for all substance use disorders. So by focusing on craving and withdrawal and insomnia, which are things that are really difficult for people who are experiencing all forms of addiction, it helps us think differently about how we might be able to help people, maybe more rapidly help more people than some of our former approaches, which were very specific to certain types of drugs.
I know we talk about the drugs for after the fact of the addiction happening. Haven't you talked before, Nancy, about wanting like a vaccine that, just
I'm really fascinated, and we are moving ahead, and I really believe this is going to be the future where you can have a vaccine, and you might have to call it a shot because vaccines are not popular, that word, but it's a shot. And I think if you can give a vaccine, there's an opiate vaccine we've been part of, and the idea is that you'd have this vaccine once, and the rest of your life you would never crave an opiate. And if you had one anyway, it's going to be blocked in your system. And you could never get high from an opiate the rest of your life, which is pretty darn amazing.
it's amazing. And we think that's something that could
We
eventually.
think it's going to very much happen.
Yeah.
And there's the idea, and the big dream I have, truthfully, and we're going to work on this, is when your child's born and you have addiction in your family, wouldn't it be great to, when the kids are getting measles, mumps, rubella, polio, wouldn't it be great if there was a vaccine you could give them that would stop them from going down this rabbit hole for the rest of their life? To me, that's the ultimate dream that I would love to be able to have. It's like very preventative, especially in families where this is very constant. And wouldn't that be such a great way to change the trajectory of that family's whole entire life? So to me, yeah, it is very possible. During COVID, vaccines became easier to make. They weren't as hard, and this is very probable this will happen.
No, that's
It's exciting.
unbelievable.
Well, yeah, one thing I wanted to point out that there's multiple exciting approaches here, and it's likely that there won't be one magic bullet that will take this pill and you'll never want to do drugs again. But having multiple treatment options will give options to the physician and the patient to best treat it in multiple ways. So we talked about orexin antagonists, we talked about AMP antagonists, we talked about GLP-1 agonists, we talked about vaccines. They will all be part of the solution, and they're making rapid progress. And I have to say, CAN has been supporting each of those. We've been putting money into the most promising research areas.
Right. For 25 years before I ever got involved here, there was zero research going on, basic science research as it relates to addiction. I don't know why. It makes no sense. There's so much research for every disease that afflict very few people. This disease affects like 50 million people in our country. I mean, come on, that's a crazy number to try to look the other way. It's a leading cause of death in our country for people 48 years old and younger. I don't know why, because of the shame. Everyone kicks this can down the road. They don't take care of it. We are actively doing every one of these things that we think is the most important. We would like to fund 10 times more things because there's so many important things. We are the only charity, by the way, that is doing that. We are the only charity that is funding, that works as a group, funding all these different things. I don't know why there aren't a lot of charities doing this. It doesn't make any sense to me.
Well, thankfully, we have yours. And we have Lisa, who is a dear friend of yours as well. And we talked about the families and being a parent, and you lost your son. You're using your platform as an actress and an advocate to get the message out about not having the stigma, that there's no shame, and really helping Nancy in her mission.
Yeah. First of all, I just want to, I know I say thank you all the time, but I just love this woman. Like,
Thank you.
I get emotional.
Love you too. We met in a very strange way.
Crazy. It's crazy. I talk about this all the time and I still get emotional. But just listening to all of these incredible doctors and the hopes and the dreams. You know, it's sort of like one part of me is so happy and so hopeful, and then there's this other part of me that's like, man, if I would have just known about this, that my son was going through and he couldn't sleep, and listening to just all these things that as a mom, we don't know. We're so unprepared. We don't have the tools. And that's a big part of, for me, what I want to be a part of changing is, I always say my son did not come here for nothing. He wasn't born, I didn't love him and raise him for him to die for no reason. And so Nancy has been such a huge part of teaching me how to turn that pain into purpose and getting to have hope and excited about the hope of what CAN does and what these doctors are doing. To me is like, I just want to get up and dance like in this whole room because so, right? I would, you know I would. Because it means saving so many lives. It means like healing so much pain in the world that is just at the hub of so much of our dysfunction and sadness and just going deeper, family dysfunction and divorce and all these other things, right? And so me being an actress and I, asking that question of why me, right? Because we all start out thinking, why me? Why? My baby boy was beautiful. Scott Cohen, beautiful, vibrant little boy, beautiful family. Why? Why did my son try out at that development program, and this other player hurt him, and he fell so badly, and he broke several bones in his leg, and they did surgery on him, and they put him on Oxy. Why? Why didn't I know? Why didn't they tell us how addictive Oxy was? Why didn't I know that maybe my son had the addiction gene? I come from a family with a lot of addiction. And that started an 11-year drug battle for him and our family, in and out of rehabs, doctors. I mean, there wasn't a stone I didn't turn over. There wasn't like a doctor. I was literally like, I would just go up to people and be like, do you know anything about this? Because my son's struggling. Like, it was just desperation. And it was 4 years ago, and it's still freaking fresh and painful. But I was like, I gotta do something. I can't just live this and move on. I need to honor my son's life, and this beautiful angel that I got to meet in the craziest ways. We're convinced the boys got together in heaven and said, these two need to meet and be together and work together and create change. And I am a person that I'm very passionate, and I have a platform, and I want to use that platform to educate, raise awareness, take away the stigma of shame, and create change, and I don't know what's going to happen to me. I don't know who likes it, who doesn't like it, who's going to look at me a certain way. I don't care. The worst thing that could ever happen to a person happened to me, so you can't hurt me is my thing, right? So if I can help, that is how I want to honor my son and help somebody else, help another parent. And Nancy and I, we started a podcast called Two Mamas Who Can, and we are talking about that pain. We're having the hard conversations because everybody needs to know that this is an illness. It's a brain illness. It's a mental health illness. It is not just somebody wanting to be bad. Nobody wants to be bad, really, right? And my son came from a loving, beautiful family, and so did Jason. And so addiction doesn't have a face. It's not just Black and brown communities. It's not just deadbeat people. It's not just homeless people. It's anybody and everybody. And I really want to be a part of being a voice for that change and that education, because if it saved somebody else's life, it was worth everything. And that's why my son came to be. And so I am honoring him that way. And that's my story.
I love that you said he didn't come here for nothing. You know, it is heartbreaking, but I know you and Nancy together are unstoppable. So that is exciting. You also mentioned that the gene, an addiction gene. Does anyone want to talk about that? And we have tests to see if we have the gene for breast cancer or whatever other problem there might be. Is there a test to see who might be having the addiction gene?
Maybe I could speak about it.
Yes,
There is no one single gene. I think everyone would agree to that. What you have are kind of these smaller kind of effect size genes where you can have a collection of genes that will influence your vulnerability. But what we're beginning to understand is the way those genes work is not like you get exposed to a drug and all of a sudden it's like every light goes off. I think that happens with lots of people. What you end up with are deficits in the systems that actually tell you that's probably bad. That's something that you shouldn't do. And it's more the brake system that doesn't work as opposed to the accelerator being stuck on go. And so some individuals, what we're learning now is as we're, understanding more about the genetic architectures that influence substance use disorders, is it's those brake genes that seem to not work as well. And so that knowledge is important because then that tells us how we may be able to intervene and develop therapeutics. Not just that this gene works in this way, but how does it work? What are the brain mechanisms? And can we turn those mechanisms up, particularly in individuals who may have genes where they're not as protected as perhaps they should be?
Go ahead.
So I couldn't agree more, and I'm so glad you handled that question in that fashion. But it's also as an example of where we are beginning to have a appreciation of the role that genetic predisposition and environmental exposures at specific times can have negative impacts, which I don't know if people have caught up with the science that is coming out about this, which is cannabis use in people who have first-degree relatives who have psychotic disorders like schizophrenia. We know that there's genetic predisposition if it's in your family, especially closely related relatives who are more likely to share those genes. And if during adolescence you use high-potency cannabis, marijuana components, it will double, if not quadruple, your chance of getting a psychotic illness like schizophrenia. And this is, a devastating illness. It's not that it makes it inevitable, but the combination of when you do it, what you do, and what your genetic predisposition is can have significant impacts.
Yeah, that's a hard one to put all together.
Right. I think the idea of people saying, "Oh, it's just pot. It's like cool. It's okay to do it," and they glamorize that, and kids have now told themselves it's not a big deal. But the marijuana they sell today is about 5 times as potent as it was when I was growing up, and the amount that you get from a dispensary that's supposedly the legalized number it does make you psychotic, and you're seeing all these young kids who think it's just cool to do it, and once they start, boy, they might have this horrible mental illness the rest of their life that they can never get over. And I think it's a tragedy that all these states are legalizing pot and acting like it's no big deal, because it's a huge deal and it can really destroy their lives forever. Until you're 21, your brain is not fully developed, and if you're using it during that time when your brain is developing, you're in a bad place for the rest of your life. How can you just gamble with that?
You drive down Wilshire now, and there are
It
more
smells.
pot dispensaries
I
than
know.
there are even alcohol.
Right, but when you're just walking around the nicest place, the nicest restaurant, wherever you go, it smells like pot.
It smells.
Or skunk.
Yeah.
Well, glamorizing it in Hollywood, for example,
Has it
It's-
changed the way you take roles and what roles you will
100%.
take? Yeah.
100%. I mean, first of all, I've been in the industry for 45 years, and I remember a time when,
Right, started at
right.
2.
Yeah.
Thank you. And I remember when, for me, as a Latina woman, that's all that was available. It was like drug addict girlfriends, or the woozy drug addict girl on the block, or it was so stereotyped, and it was awful. And there came a point where I was like, I think I'm going to have to quit this business because these are not the kind of women I want to represent. These are not the women in my family. I come from, hardworking women, loving families, and I was just so blown away by that. And now I play a lot of doctors and lawyers and cops and detectives and moms. And so, but I had to decide that, I had to choose that. And so now I'm very outspoken about not only how Black and brown communities are represented in roles in Hollywood, but also glamorizing drugs and drug use and how it is hurting our young children. And I don't think enough of us as a society, as parents, as adults, are speaking out about it in a strong enough way, in a powerful way, where we are impacting it and we are not spending our dollars on these films that are glamorizing these drugs and television shows.
Yeah.
You know.
It feels like it's everywhere. Dr. Kathryn, we haven't really been able to hear from you yet, and I know you deal with the treatment and wanted to see what changes you've been seeing in the treatment for addiction.
I was just thinking about it.
I think you just have to jam it
Jamming
right
it.
up in your mouth, yeah.
I was just listening. I was just listening to this conversation.
Deep throat.
Of course, Nancy.
Sorry.
Sorry, it's okay, really sorry.
I was just listening to this and how important it is that we think about it in the start and during development, because we have just started a clinic about a year and a half ago. I live on an island, Galveston, Texas. It's an old island, and it has a beautiful shoreline. And every morning when I walk on this, as the sun's coming up, I find people sleeping in the grass and sleeping on the benches. And because it was challenging to find individuals, women, by the way, young women, sleeping by themselves on the beach, we started coalescing a group of individuals in our community and developed a substance use disorder clinic for free, that is free, completely free. It's funded by philanthropy. It's actually funded right now because we are treating our patients with GLP-1 agonists to see if we can improve their retention. But the biggest challenge is that we are trying to change the stigma in our community. Individually, I'm stigmatized because I'm an addiction scientist, and I bet you everybody else has had this experience. We are not as important as cancer scientists. They have an important disease to fix.
That's really interesting. I never
crazy.
thought about
It's-
that. That's
I
really
bet you everybody sitting up here has experienced this.
And not just the scientists, but the physicians.
And the physicians, that's right. And that's why it is so hard. We started this clinic, and I went to all the psychiatrists at our campus, not interested. Who is treating patients? Internal medicine docs, pediatrics, not psychiatrists. And you don't have to be a psychiatrist to do this. It is a very straightforward way to treat people, but you have to have access. You have to have access to medications that work, and you have to have access to treatments, psychosocial treatments that work, and we know they work.
I find that really fascinating what you said, because I think there's stigma on the person who's using, there's stigma on their family members, that maybe they're not a good parent or a good spouse or whatever. I never thought about that that the shame exists towards the doctors that are taking care of them. I never heard that. That's really
Yeah, actually, Andy Chambers sitting behind you is an addiction psychiatrist, and I think he can tell us about how difficult it is to get psychiatry residents to go into addiction psychiatry.
Yeah,
Wow,
it really is. It's
really interesting.
it's really shocking. Because we're trying to train our psychiatrists to not stigmatize mental illness, right? It's part of the training. And addiction is a type of psychiatric biomedical illness, and some of the trainees themselves selectively stigmatize that illness, right? Even though so many of their patients have addiction. And I think the other thing that we have to grapple with, you all, is, there's different types of stigma. There's all kinds of forms of it and way it affects. And, we're up against a real hard problem here, because the two largest institutions in the United States that are participating in the stigma is the government and the criminal justice system and the healthcare industry. And you get into why is that? Why are these this is who we're up against in part. Now, why is that?
I never thought of that.
Yes, and here's how that works. The criminal justice system, in the United States is the biggest in the world in terms of per capita incarceration. We incarcerate more of our own people than any country on the planet by a long shot. And that is because we have criminalized mental illness and addiction. That's why. The vast majority of all these people who've been incarcerated, so there's a lot of power in that. There's a lot of political power in that, and money in that, in the whole incarceration industry. That's how it happens on the government side. On the healthcare industry side, if you do not treat addiction, if you're a huge academic medical center and you don't really offer much beyond a token or kind of facade of services, and you have no addiction psychiatrists, on your faculty. So what's going to happen? You're going to be treating a population where addiction is incredibly prevalent in that population. And as they are untreated, they accumulate all manner of injuries and medical diseases that are extremely lucrative to treat. This is what we're up against.
Corruption.
Right? It is corruption. So you all notice that our healthcare system is broken, right? We all know that. And this is one major way it's broken. And when it comes to the behavioral health side, we also have, it's unbelievably fragmented. It's the inpatient world and the outpatient world are disconnected. Mental health, addiction, and addictionology totally disconnected from each other, even though the patients are often very overlapping. I mean, if you have a mental illness, the odds you're going to get addicted are huge. If you have an addiction without a mental illness, you're going to end up with some kind of mental illness during that addiction. So people fall into the dual diagnosis bucket, and we don't have treatment systems for this because we're so fragmented into these little pieces. So it's like a patient who's trying to navigate this has to island hop, right? And so much of it is outside normal healthcare insurance coverage, right? And so we really have to, the American people need to kind of wake up to this, right? Because this is an American problem. We're doing this wrong. And there's so many ways the rest of Europe and the Western world are doing it better. So we have a scientific need, but we also have a treatment infrastructure and education need. So it's kind of they go hand in hand, and I think that's also really important that all this has come up today.
May I also?
Sharon, may want to add something?
Yeah. Yeah, and I want to add something very quickly to that. Go ahead. Sorry.
Okay, thank you. I just wanted to amplify what my colleague here said, because for years we would see young people admitted to the hospital with really life-threatening infections in their heart from injecting drug behavior, endocarditis. They would need a valve replacement. What do you think that cost? $250,000. You could see somebody in their 20s coming in, getting one, and then maybe even coming back and getting another. But the underlying reason that the person presented to the hospital was the substance use disorder to start with, right? That's how they ended up with this thing that then we're treating and ignoring actually what led them to be there. And so if you don't offer treatment universally, or you don't even offer screening universally. So I've lectured to physicians and I've said, so how many of your patients do you think have a substance use disorder? And they'll say, well, none. Well, it's like, where are you? Like, of course, that's completely wrong. You're not asking the right questions. It wasn't really until pretty recently that we provided any training around substance use in medical schools. I mean, that really came about because of the opioid crisis. Before that, medical students would go through, get an MD, start practicing. All physicians see people with substance use disorders and the consequences of them. And all of them should be able to treat them. And when you ask, like, what would your dream be of the thing that would change? Mine would be that we actually had a seamless treatment system that didn't isolate substance use outside of everything else, where everybody was educated and could do screening, and that we could have medications available in office-based practices for all disorders. right now, I mean, we have families on this panel who have been through this and know how incredibly challenging it is when you have a child with a substance use disorder to try to find quality care. You can find care that actually has no basis in evidence and spend a fortune on it. That's not really that well regulated. So having quality standards and having kind of a seamless transition from inpatient to outpatient and thinking about the patient as a whole. And I'm just going to say one final thing, and that is that lots of people end up with a substance use disorder because they have some antecedent conditions. They've got trauma. They've got other anxiety, depression, things that are unaddressed. If you address the substance use disorder with something that allows somebody to simply detox, that other thing is still there. That needs to be treated. And when someone comes out after having substance use disorder for a really long time and they're successful and say they do become abstinent, that's the beginning of the path of recovery because you've lost a lot of other things away. So we have a lot of people that come out. They have charges now because using drugs is illegal, and now they can't get a job, or they can't get housing, or they can't even get recovery housing, or if they're on a medication for substance use disorder,
Can't get insurance.
they can't get insurance. Exactly. So we set people up to fail. So we need to think about it holistically.
That's what I wanted to quickly touch upon is that, especially because I'm very involved in different things for the Black and Brown community, especially Latino community. We are not treating the original trauma. It's going ignored, especially in these communities where there isn't enough funds, money to go to therapy, to deal with the trauma, to deal with the poverty or the abuse, things that are happening. We have to start way back before we can think that we are going to come up with a real healing solution in addition to the medication and the trauma and the broken medical system. That is honestly one of the number ones, and this is an American problem.
Yeah.
It's an American problem, and we're ignoring it, and we're glorifying it.
And also so many people, you hear about 20-year-olds, 25, 30, 35-year-olds, oh, they were in the shower and they had a heart attack and died. And nobody's delving in and is saying that relates to addiction. It's really abnormal to die at that age of a heart attack if you did not have this problem, but they don't want to talk about it. Again, the shame hits in, but the cost of getting somebody better, in that light that insurance doesn't cover anything. When you go to rehab, if they cover a blood test, you're lucky. You have a lot. I mean, people are mortgaging their houses to save their kid's life. And not all the rehabs are that great. I mean, there's some that are great and they're not great. And they sometimes look at you and figure out, how much can we get away with charging that person? That's what they do. They don't have like something that's printed of how much the place costs, but they look at you and say, how much can we get away with charging you?
A sliding scale, if you
It is
will.
a sliding scale. And if you might have a roommate at rehab who paid, a tenth of what you paid, but they thought, maybe they have a little money and we'll charge it. But it's the most expensive disease, period, to try to treat somebody. And there's no backup that these things actually really work that they're doing. And 40% of all people who work in a rehab have zero medical training, and that they're giving, medicine, they're detoxing, they're doing all these things. They don't know what they're doing, and it is so unregulated. You're correct, but I didn't realize the part that they shame doctors who were in addiction too. But it seems like it's just shame all around.
That is so
really
surprising.
unfair. I didn't know
So
that.
surprising to
I was
me.
glad to. I mean, I'm glad to know that, but it's terrible.
I need to add to that really quick. I've been through, what is it, 3, and I don't know if I mentioned this before. My drug of choice was meth. So I don't even think I said
No, you
drugs,
didn't. Yeah.
but yeah, it was definitely methamphetamines. Very, very difficult to get over. But I had the opportunity to also go through state-ran free treatment centers. Also ones like the 50C3 treatment centers, and then also this last one right behind me, West Hollywood, was a very nice one. So I've been through all three, and I'm going to tell you the difference between the help of this state that doesn't, I mean, it's just like cattle, get them in, get them out, and then they're back in jail, over and over again. The difference between a good treatment center and a state ran is huge. Like, I've been sober for 5.5 years now, and that was my last treatment center. I'm not saying I couldn't go out and use tomorrow. It's just the quality of care that I got here compared to other state ran facilities is just amazing. Like, even the workers that go to them that get paid nothing to, watch after these people and cook for them and this and that, it's completely different.
I wanted to check and see if there's anyone in the audience who has a question, a personal experience, or something they want to ask. These are the experts, so this is the best time to do it. Go ahead, Mom. I'm going to call you Mom.
I was wondering if NAD has come up in your research for addiction.
NAD?
N-acetyl.
I don't dare even try to say it.
My understanding is that there's very little kind of basic research to show what that's doing. I guess a supplement that modifies energetics in the brain and throughout the body, but
I actually, at my treatment center, I got, I think I did 3 what they call bags of IV, and it helped cure the swelling in the brain. And I could tell a huge difference in it. So I was just wondering if that's...
I can't remember on the panel who said this, but the one thing about any treatment that'll work is a great treatment. I guess that's obvious, but with treatment centers, my major concern is they're not evidence-based. And so when you go to a treatment center, they will basically throw the book at you, and everyone basically gets a different treatment. And it's really unclear what works and when it works and how it works. And so no 2 people ever get the same treatment. And that's because of, generally speaking, a lack of an evidence base. And I think that, again, speaks to the broader problem we're talking about here in terms of, it's not really, addiction medicine is not really part of general healthcare. And so we don't really know what works. And so I think you talk to 100 different people who have undergone treatment, and they'll have 100 different stories. And they, if they were given a small molecule or something in addition to the therapy, likely everyone got something different as well.
Yeah, and it's all really, at that point, was about money. What can we sell these people to make them think this is the...
Unfortunately, there's a lot to that, yes.
And I just would add, because Lisa brought it up, that, with inflammation, which is what I study, how inflammation causes things like depression, which is what you see in multiple sclerosis. And then when you add to that, for instance, often people feel the need to self-medicate rather than go get seen, and then they start drinking. Well, guess what? Alcohol is like pouring gasoline on a fire. It causes depression, even though temporarily it makes you feel a little better. So then you're off to the races. So that, to intervene with anything, to break those cycles can be an important step.
We have a question back here.
I was just going to say, hold the mic to you so we can hear me.
Yes.
I just want to say that I relate to the shame. When you stop having shame about your disease, that it really changes you so much. I came out to Promises in 2001 because a friend of mine got me out of a state-run institution in New York and sent me to Promises. I had to pay for it eventually, but they really taught me that, this particular place taught me that, it's a disease, there shouldn't be any shame. And I ended up taking back a sober companion for 10 months to live with me, to keep me from, relapsing. And because they understood that I was going back to my family, which was really just like a venomous nest that would, loving people, but they just don't know how to handle, what you go through. And I just want to say that totally changed my whole view of not having shame about it, but I still struggle with it, but I just wanted to say that once I understood that it's really the business aspect of it, that people are preying upon us, I kind of fought back a little bit harder.
Thank you for sharing that. Is there a way, and we'll get to you in just a second. I just wanted we were talking about the shame and the stigma and how we talk to each other. Is there a way we can change the language for which we talk to people so that they don't feel bad when talking about, is there a different way we can speak to people?
Think about all the pejorative words that are used to describe people that do drugs. That's why no one wants to speak up. And there are wonderful strategies now available through our states and governments, believe it or not, that are actually very critically thinking about how do we make sure that we are not continuing the stigma. I'd love you to come visit some of these places because it is truly acceptance. It's not abstinence 365 days a year. And if you fall, you come back, just like you do every week, and we do it again. And it takes time. So I think we can do it. And this is exactly what CAN is trying to do. And you can't do it without dealing with stigma.
Yeah.
I've been stigmatized. I told you, I've been stigmatized my whole career because I study this.
Yeah.
So we got a long way to get back, but if we bond together,
And start
we
changing the way we speak about it. Yes, Dr. Kaplin?
So I just wanted to underline that we actually do have studies, believe it or not, that say speak up. So one of the studies that you may know of but not know this part of it is the Milgram experiment, where somebody in a white jacket would stand there and tell people in a room, to keep turning up the electricity if someone got a question wrong across the way. And 80% of people would go to like dangerously, potentially lethal doses of electricity. Everybody says, oh my God, bullies can really make you do anything. But what they don't know is if one person in that room stood up and said, no, this is wrong, this should not be something people are doing to other people, 80% of people would stop doing it. So
think about it then, though. That's the difference. It actually makes you think, right?
So stand up, go home, advocate for what you care about. Give money to CAN, please help support the research, but stand up in your own ways. I don't know if everybody feels that way, but having bullies in charge is something that isn't so alien to some of us these days. So stand up and be heard and make a difference.
Thank you. I know we had a question. Right here. Okay.
Somebody over here.
Hi.
Too,
Okay.
afterwards.
Hi. My name is Emily Jackson. I want to thank the panel and thank Nancy for your research and your care. I am a recovering alcoholic and addict, and I have 2,994 days and nights in a row. It's a conscious effort because it's only 24 hours that this disease is arrested. My father is a physician. He's a surgeon, or was a surgeon. He's he's a urologist. And all four of my siblings are addicts. And it was really rough where he couldn't fix it. And, I'm 63 years old, and I'm telling you, back then, you didn't talk about how you felt, He couldn't fix it. And if we talked about what problems we were having. So my cry for help is, I'm a biologist, a biochemist. I got into medical school and dental school. But my addiction, the disease, what is the definition of disease? Chronic, progressive, and potentially fatal. My siblings all died from cancer, but the predisposition was addiction. If you're smoking crack and you have a chemo appointment, what are you going to do? You're going to look for more crack. I go to meetings. I'm in several fellowships. I know that the Los Angeles jail is the #1 mental health institution. We know that substance abuse is part of homelessness and I have been at the low from Yale to jail, they say, is that it does not discriminate. But I do want to speak up on behalf of the Black and brown community as an African-American woman. Forget it. The stigma is absolutely horrendous. The dollars that go to African-American women are just dismal, not just in healthcare, but in nonprofit organizations, everything. So I'm speaking and coming from a place and representing a community that is underserved, and we need help. I'm here, and I'm so, my best friend, who is a psychiatrist, lost her son January 15th to an overdose of fentanyl. She called me that morning, and I was on a plane that morning, because it is so crucial for us to help each other deal with, and the stigma. I mean, I work for the National Institute of Allergy and Infectious Diseases at NIH. And what I realize is that there is no pathway. The shame, I can't get a job because of a felony conviction for trying to sell cocaine as a means of wanting to, money. I come from Potomac, Maryland. That's where I hail. But it doesn't matter. And because of this stigma, it goes on and on and on. I mean, most people look at me and they're like, oh, you're all put together. No, I have to deal with the disease one day at a time. What I have to do in the morning just to get centered and to be, quote unquote, normal, is absolutely, it's tiring. But again, I'm going to fight, and I want to be here, and I want to, anybody that wants to, work with me, I'm here to support Cure for Addiction now.
Thank you so much.
Thank you for sharing.
That's true. Like, we are so unforgiving as a society. Like, I think you were saying this, right? Like, you in and out of prison because you was like my son. I had my son 5150'd 3 times, and they would let him go home, even though I was like, he's threatening suicide, and they would just ask him, are you going to hurt anyone or yourself? And he would say, no. Okay, you can go. Guess what? My son killed himself. He shot himself in the head because he couldn't take it anymore. Okay? So, yeah, we're not paying attention. We're not taking it seriously. We're unforgiving. We're calling addicts criminals, losers. You went to prison, guess what? Your life is going to suck for the rest of your life. If you decide to live, we're not going to let you work anywhere. We're not going to let you live anywhere. We're not going to allow you to be around certain people. It's so messed up. It's almost like stabbing, putting in the last knife to kill them, and it's just so bad. And we as a society are actually actively doing that, and it's shameful. That's shameful. That's shameful.
Which is also wild that it's
Oh, okay.
Episodes as adults. Is there anything relating to that for ADHD medicine, like Adderall, Vyvanse, or all these, like, can that be a precursor to like amplifying addiction?
So great question. So ADD, ADHD is actually quite controversial. We're not certain about this construct. It's more, our understanding of it's more evidence-based in terms of children with ADHD, but the issue with ADHD, especially when you diagnose it in adulthood, is this. There's several issues, but the problem is that basically all forms of major mental illness cause attention problems. So it's a symptom that's embedded in bipolar disorder, PTSD, schizophrenia, schizoaffective disorder, borderline personality, antisocial personality. Attention problems are spread out. the problem is that all those diagnoses I just listed are also addiction vulnerable states. So one of the emerging problems we're seeing is the overprescribing of stimulants, which are super addictive drugs. Meth is a stimulant. Adderall is a stimulant. They're very closely connected drugs. One of the major problems we're beginning to see is these drugs are being overprescribed, and they're being overprescribed to people who are addiction prone. And so that's, on the other hand, there's a lot of people very enthusiastic about stimulants. And it kind of reminds me of where we were 15 years ago, right? Where a lot of emphasis on opiates and pain, right? And let's get these drugs out the door and move them and get everybody on them. And anything that walks in the ER needs an opiate. And, we're some of us are very afraid we may be, repeating some of this history, but yet with another drug, right? And so I think that it's very controversial. Of course, there are people who are adults and children who have ADD and need the appropriate treatment, but are we entering sort of a new sort of iatrogenic, problem with a different class of meds for a different neuropsychiatric problem? And that's a big question mark.
The only thing I want to say is, as a psychiatrist myself, I know when I hear people badmouth antidepressants and this kind of stuff, and my patients come off and become suicidal, that there are many people, as Dr. Chambers said, kids who do very well and really have trouble with focus and attention. So before you take your kid off, please talk to your doctor, and if you don't trust that person, please get a second opinion and the like. But it doesn't cause schizophrenia, so that is pretty clear.
I know you have been so patient waiting back there with that microphone, so make it a good one.
All right, I don't know if it's a good one, but first of all, Nancy and Lisa and the two other folks here that shared their stories, thank you so much for sharing. My family was affected by the opiate crisis as well, and that led me to start a business, to try and build a business to help those that are affected by it. So I'm very, very passionate about the same things that you are passionate about. We've been fortunate to be supported by the NIH and by the National Institute of Drug Abuse for our project. But the question I have especially for the clinicians on the panel, as well as for those of you that have lost folks, lost your loved ones, there are 3 medications that are FDA cleared to treat opioid use disorder, and none of them have been mentioned so far: buprenorphine, methadone, and naltrexone. And I'm just wondering, from your perspective, how do they fit into this discussion? And did any of your children ever try those medications, and what were the results? I'd just be curious about that.
So I'll start with some introductory comments, and then maybe the families can comment. So you're right, there are 3 FDA-approved medications, and they're all slightly different. And methadone has been around since the 1960s. Buprenorphine was finally approved in this country in 2002, and naltrexone has been around since the 1970s. For buprenorphine and methadone, studies have shown that for individuals that have opioid use disorder, that they are 50% more likely to survive if they are actually receiving medication, one of those 2 medications, than if they are in active opiate use and not receiving them. So being in treatment with methadone or buprenorphine are life-saving at the rate of 50%. So if we have a medication for any other life-threatening illness, where 50% of the people are going to survive because they're taking the medication, you would think that everybody would have access to the medication and everybody would be taking it. But that's not the case. And what we know is that on average in the United States, less than about 25% of people who are suffering from opioid use disorder in a given year will actually have taken one of those medications. It doesn't say how long they took it for. They only work when you take them, just like your medications for diabetes and depression and everything else. So we have to work to help people stay in treatment as well. But we know that they're really highly effective. Those 2, highly stigmatized and very limited in availability by the structure that we've set up in this country. And it's quite different in other Western countries where it's much more accessible and much more mainstreamed.
Lisa, Colby, Nancy, did your kids or Colby, were those medications that you tried at some point?
No,
There are no medicines for Colby's
no,
addiction.
there's none. I think they used to actually detox meth users, but I don't think they do that anymore because you just get really sad and hungry.
That is striking that there are no medicines for which Colby's addiction, would respond. Same thing with marijuana, same things with cocaine. We have no
I
treatment.
did take Jason to a doctor who had suggested naltrexone, and Jason was very against taking it. And he told us a lot of people on naltrexone commit suicide, and he thought he didn't want to add that to his list of things that were going on in his life, and he chose not to take it.
My son did. We tried methadone. I was driving him to this seedy, low-life looking little place where nobody, honestly, they didn't talk to us about what was, like more intricately, like what should I do as his mom? And it was always just me taking him, and he was like hopeful. But honestly, it made him so sick. It just was not working for him. And then he was on that other medication, I'm blanking on the name of it right now, where it's still addictive, but it's supposed to be less, help me out? What is it? Suboxone.
Suboxone. Oh, mine went.
How can I forget that name?
We went.
He was on,
My son went on.
he was on Suboxone.
But a lot
But
of
it
people
was
get
like,
addicted to Suboxone. And
that's what
never
happened.
Get off of it.
That
So
was,
it's
it was just
not
like,
good either.
yeah.
I just want to add one quick thing. I did a genetic test using GeneSight. Told me exactly what antidepressant to take. Started taking bupropion, and I will tell you that my doctor also started me back on Ozempic. And this is before all the celebrities were using it or anything of that. I have stopped obsessing over alcohol, drugs. I'm also a food addict. I'm a sugar addict, which is actually alcohol. But anyway, I can't tell you what success. And on top of that, I dropped 36 pounds. And I am doing actually my own study. I did a gastric bypass. 2 days later, no more needing insulin. That was 13 years ago, and put my diabetes in remission. But I will tell you, in the last 2 years, I've had more success. I don't play backgammon live addictively. I don't drink caffeine. Well, I was drinking, I had coffee with my butter pecan ice cream. I don't smoke. I have no desire. And I just want to give you some hope. It may be just me, but I believe that the GLP-1s, semaglutides, are the pathway.
We're doing a lot of research with those right now. We have 2 studies that are funded, and Paul Kenny here is doing one of them. He's amazing, and they seem to really help, especially with drinking, and they're quite amazing. I think they'll be the holy grail for other diseases as well, including Alzheimer's, by the way, which is pretty
So important. Sir, you've been waiting patiently.
So my name is David Moore. I'm the Community Engagement Director for Impact Treatment Center in Pasadena. We're a Medi-Cal-based treatment facility. Full disclosure, I'm a product of Impact 7 years ago. For Dr. Kenny, you mentioned something about it being individualized care. That's kind of like, our cliche in treatment. We need to do the individualized care because that's like a selling point. We will take care of you personally. But then it defeats the purpose because we can't figure out what works or what doesn't as far as interventions. What can treatment centers, being an aspiring student researcher at USC, what can treatment centers do differently or better to take better data on what interventions are working or work with the research communities?
Yeah, I think the key word you use there is data. If you have enough information, I think patterns begin to emerge. That's something I've been trying to work with some treatment centers in Florida, which is there's no doubt that treatments work, and they work for individuals. I'm not saying they don't. And I'm not saying that treatment centers are not trying to do their best for their patients. I think they are, And, obviously there's economic motives there as well. But everyone does different things, and I understand that has to be patient-tailored, but if you can collect data and enough data, I would imagine the patterns will begin to emerge. And then if you can link those data to the patient in ways that are meaningful, then you can make predictions about what would work for the next patient to come through the door. Big health systems, of course, I work for Mount Sinai, one of the biggest health systems in the US. This is something we're trying to think about right now, which is, it's, as much information as you possibly can about a patient, and maybe there's other things that are predictive of disease outcome, the disease here being addiction. We just heard about other comorbidities that are known to be heavily associated with drug addiction that respond to GLP-1 stimulation. Quite often, what is likely happening is that the use of a drug compulsively is actually rendering you more likely to develop these other diseases. And sometimes those other diseases undoubtedly are influencing the addiction cycle. So I say all of that because we don't really understand any of those relationships because we don't have the data. So I think we're at the stage now, and as a field, where we really need to begin to increase our understanding by collecting as much data as we possibly can about patients, including genomes if possible, so we can understand genetic vulnerabilities. So data, data, data.
Thank you, Dr. Kenny. Kelly, you have something?
Yeah, I just wanted to add that Cure Addiction Now actually funded a study that was conducted by Dr. Justin Strickland, who's in the audience here, to embed wearables like Fitbits and things like that into a residential treatment program to be able to collect really sensitive data on people as they go through the recovery process in hopes of being able to grow a data set like that over time to predict the likelihood that somebody might leave early or the likelihood that their withdrawal would need different types of treatments and so on. So I agree. I think just having more access to data now with the advent of all of these wearable technologies that we could collect, they're commercially available, we can collect the data from them and use that to be able to understand more about the experience.
I want to thank everyone who came out today and everyone who's watching at home. I want to thank the doctors, the researchers for sharing their knowledge and their tireless work, as well as Lisa and Colby for sharing your story and banding together with Nancy to really make a difference. And I know if anyone can do it, Nancy Davis can. And she's surrounded herself, as always, with the best and the brightest.
Including you. So thank you so much for being our moderator today.
Thank you.
You are the best and brightest.
I think the compassion, the care, and the dedication is unbelievable.
Thank you for doing this. It's a big, bad disease, and we have a lot of work to do, as you can see, and there's not one size fits all. So we need to go in every possible direction and find the best things to help people at rehabs and different places know how to deal with their individual disease. Not everything is going to work for every person, and we're there, and I feel thank you to everybody. I feel my son Jason. He would be so happy to be here and see what is going on today and
the sunset.
And I'm seeing there's a sunset. I can see it right over there.
Just as we're
wrapping up, this was his dream. He really cared a lot, and he just so badly wanted to find a cure. So that's what we're going to do.
Amen. Yes.
Thank you all for being here.